Hello, everyone. I'm Dave Iverson, the contributing editor at the Michael J. Fox Foundation and the moderator for our continuing series of webinars, the Third Thursday webinar series. Today, our topic is pain and fatigue in Parkinson's disease. As most of you know, you can join us on the third Thursday of each month at 12 Eastern, 11 Central, 10 Mountain, and 9 Pacific to hear a discussion about important topics in Parkinson's disease. And we hope that you'll continue to mark your calendars and join us each month so that you can participate in our conversations. And you can also always watch these webinars on demand whenever you like. Throughout our hour today, as always, you'll be able to participate in our conversation by joining us throughout and by writing down a question and posing them to our experts. There's a Q&A box that you'll see in the middle of your screen, so you just need to type your questions on that and submit them, and then we'll do our best to respond to your questions the best we can over the course of our hour. We'll also provide the slides for today's webinar for download, so you'll see a box called Resource List on your screen. And you can click on that, and then that document will open in a new browser window, and you'll be able to save or print that window later, and then you'll be able to save that and print that up and save that for later. So let's get right to our topic and discuss some of what we'll be talking about today with this topic on pain and Parkinson's disease. We'll talk a little bit about the kinds of pain that are associated with Parkinson's disease. What is pain in Parkinson's disease? This is actually part of the disease itself. What is it that physicians can do to contend with Parkinson's pain? What is it that people with Parkinson's disease can do to contend with pain themselves in dealing with this condition? What about fatigue? What exactly is that? Is that also part of the disease? What medications and practices can help manage fatigue? And what are we learning about these, both Parkinson's pain and Parkinson's fatigue? What is research teaching us about both of those things? Here's who's going to be joining us throughout our hour today. Tony Palumbo joins us. Tony is joining us today from Fort Myers, Florida. Tony was diagnosed with Parkinson's disease a dozen years ago at the age of 48. She's contended with both pain and fatigue as a result of her Parkinson's disease, and we're really happy to have Tony joining us today. Tony, welcome. Thanks so much for being part of our conversation today.
Thank you for inviting me, Dave. I appreciate it.
We're really pleased that you could do so. Joining us as well is Dr. Julie Phillips. Dr. Phillips is a chair of the Department of Neuroscience and Experimental Therapeutics. She joins us from Albany, New York, where she is professor of neurosurgery at Albany Medical College. And Dr. Phillips, thanks as well. Really pleased that you could be part of our conversation. And joining us too, also from Albany, is Dr. Adolfo Ramirez, who is associate professor of neurology and the Phillips Endowed Chair of Movement Disorders at Albany Medical College. Dr. Ramirez, thanks as well for being part of our conversation.
Thank you very much for the invitation. Looking forward.
So let's begin by talking about this subject of pain. And Dr. Phillips, let's begin with just this idea that pain is actually part of Parkinson's disease, because I'm not sure that that's always commonly understood, that pain and Parkinson's kind of go hand in hand. Is this something that we're just only sort of recently coming to understand, that in some ways pain is as much of Parkinson's as is a tremor?
Absolutely. You know, I think now that we have medications and different therapies that help with a lot of the traditional symptoms we think of with Parkinson's disease, we're starting to realize that there are some non-traditional symptoms that don't involve movement that also occur in the disease. And pain is probably the most common of these things. In fact, more than 3/4 of people with PD experience pain, and this can be at any point during their disease process. It can even be before a diagnosis.
And Tony Palumbo, as someone who has lived with Parkinson's now for a dozen years, describe some of the pain that you've experienced did it even precede, for example, your own diagnosis?
Yes, it did actually. The pain initially started in my joints and muscles, and that's where I would have pain. And the pain levels, they change. They can change from day to day, hour to hour. I may have pain at a level, say, 1, and then it will shoot up to a level 10 without any warning. I also suffer from dystonia, which is quite painful. And it's either the initial diagnosis of the dystonia was where my arm would freeze and my toes would fan. Most people with dystonia, their toes curl, and mine was just on the opposite. They would curl up as if someone were ripping my toes off.
Let's dig into a little bit of what Tony Palumbo just described, Dr. Phillips. First, on the point she made that her pain can vary so much that it could be, as she describes it, a 1 one day and a 10 another. Is that common? We've had a couple of people write in already. Why is my pain severe one day and disappears another? Is that a common experience, that it can be so variable?
Absolutely, and that's actually more common in chronic pain in Parkinson's than it is in chronic pain in the general population. And I think that has, a lot to do with the fact that different days are different for different people. And, I think in seeing many patients, what's often common is how unpredictable days can be in terms of motor symptoms as well. So, again, I think this is part of the disease where you're going to have these days that are far better and far worse than other days. However, I think that that's in general terms, and when you think of chronic pain separately, there are days where, you feel it. If you have back pain and you've done something and pushed yourself the day before, obviously it's going to be worse the next day. Similarly, I think if you're under either physical or mental or emotional stress, or you haven't slept well and you're fatigued, that can make the pain worse too. So I think there's some things that are directly related to Parkinson's that can make it vary, and there's some things that are directly related to pain perception in general that can make it vary.
So, Dr. Ramirez, one of the things that seems to be coming through in this very beginning part of our conversation is that pain, not unlike so many things about Parkinson's, is variable, just like many other symptoms of Parkinson's, as Dr. Phillips is suggesting, like a tremor can be worse one day than another, or feelings of muscle rigidity can be worse one day or another. So too is it with pain. And does that also then suggest that pain is susceptible or can vary in its experience based on how you're faring with your Parkinson's drugs? In other words, if you're on with your dopaminergic drugs, if you're on the right dosage of carbidopa, levodopa, that pain should be moderated in the same way that a tremor might be moderated. Would that be correct?
That is correct, Dave. As a matter of fact, one of the initial strategies that all of us as clinicians employ when we're dealing with Parkinson's-related pain is identifying what may be the mechanism or the cause of pain. As we will discuss a little bit later, there are different forms of pain and different mechanisms of pain in Parkinson's disease. And after we try to identify that specific mechanism, one of the number one things to attempt is to maximize the control of motor symptoms with dopaminergic medications. We know that the use of medications that improve dopamine can help with pain, particularly early in the disease. As time goes by, the effectiveness of those medications may not be as good, but early on, the strategy tends to concentrate in reducing off times to try to improve pain, and that's commonly what we see in clinic.
And let's go back to Tony's story again. And Tony, if you would describe a little bit more the other form of pain that you described, which was dystonia, that intense pain that can happen as you described it. So it can be a kind of fanning out of the toes, in your case, more of a curling or a cramping. I'm going to ask either Dr. Ramirez or Dr. Filippis to describe more what's going on physiologically. But tell us what the pain is first, and then we'll hear more of what's going on physiologically. But tell us what that feels like.
The actual pain, it literally feels, when I have a fanning out pain, it feels as if my toes are being ripped off my feet. The pain is quite severe. Even though when I'm off my medications, say I'm on an off period, the pain hurts slightly. It's like a little reminder, a little tug. It's medicine time. And sure enough, it is medicine time. And then I also have a cramping in my arm that I get where I guess my arm would freeze into place from the dystonia. I guess my muscles are fighting each other, if I understand dystonia correctly, where my muscles will start hurting and aching as well. And it depends on how off I'm my medications. It becomes the more off, the more severe the pain.
And we'll talk more in a moment. Yeah, go ahead, Dr. Ramirez.
Oh, thank you. I just wanted to say what Tony is describing. She's describing this phenomenon of dystonia, these abnormal muscle spasms and posturing movements that are very common when the medications are not working in Parkinson's disease. So dystonia can be seen in a variety of conditions, but she's absolutely right. What tends to cause dystonia is this abnormal fighting between different muscles and leading to these abnormal repetitive postures. And dystonia can be extremely painful. And the most common form of dystonia is the dystonia that occurs when your medications are not working, at off dystonia. And that one in particularly can be susceptible, or the pain can be treated with adjustments of the dopaminergic medications to minimize or resolve those off periods. That's one of the forms of pain in Parkinson's disease that can be treated with dopaminergic medications to avoid those fluctuations, those on and off periods. I just wanted to make that point.
Thank you. We'll talk more about some of the other treatments in a moment, but I want to just review a couple of other points on this slide before we move on to some other points. And I want to jump to the bottom of the screen, Julie Filippis, if we might, since we've been talking some about the benefits of appropriate Parkinsonian medications and how they can help alleviate pain, and spend just a moment on sometimes the other side of this, which is dyskinesia. Dyskinesia, as we know, are those excessive movements that can sometimes take place through long-term usage of the carbidopa-levodopa drugs, which can be so helpful in Parkinson's disease, but that can sometimes cause these excessive movements. And those excessive movements can sometimes cause pain. So describe that other side of this problem, Julie Filippis, and the pain that can sometimes be associated with dyskinesia.
Yes, so dyskinesias, as we know, occur after usually about 5 to 7 years after taking medications, and, are not actually part of Parkinson's disease, but part of the treatment of Parkinson's disease. And, I think that I heard so many times early on in my career that, dyskinesias weren't bothersome for people, and, the more you talk to people, this is simply not true. While people prefer being on to being off, these can be quite painful. And so just as, you need to treat the types of pain from dystonia that are related to medication on and off times, you need to think about what your medication regimen is if you're having painful dyskinesias.
Okay, let's push on. I know there's some other points here that we haven't quite gotten to, pain and constipation and other kinds of musculoskeletal pain. We'll get to those as we proceed, but I want to keep going and talk more about the ways in which these kinds of pain can be treated. So I'm going to move us on to our next slide here and talk about the other ways in which we can treat pain in Parkinson's disease. We've talked a little bit already about the importance of adjusting medication and making sure that medication is appropriate. And it brings me to a question that already someone has written in about that I want to pose to you, Dr. Ramirez and Dr. Phillips, which is someone has already written in and said, well, what doctor should I see if I'm experiencing pain in Parkinson's? And I guess it's a great question, I think, to raise, Dr. Ramirez, first, because you should start, it would seem to me, with your neurologist, with your movement disorder specialist, because you want to make sure your Parkinson's disease medications are right. But it's a complicated question in part because I think it's fair to say that treating pain in general is something that physicians of all forms struggle with. It's a complicated question.
It is a complicated question. You're absolutely right. But I completely agree with you. I think that the initial point of contact should be with a neurologist taking care of patients or the movement disorder neurologist. The main reason for that, as I mentioned before, is that you really want to know to try to understand the mechanisms of pain. What is causing pain in these patients, and you want to try to maximize the use of medications to treat the motor symptoms of Parkinson's disease using dopaminergic medications first, and trying to understand what's causing the pain. Is this a dystonia? Is this a painful dyskinesia? So we need to adjust medications for that. Are the pain episodes occurring primarily during off times? We need to get rid of those. Is this a pain related to maybe neuropathy or a problem related to sciatica or lower back pain? So the neurologist can be a really good starting point to try to identify what's causing the pain and start treatment. I must say that to be successful in the management of pain in Parkinson's disease, you need a multidisciplinary team. You need to get the physical therapists involved. You may need to get the neurosurgeons, the pain experts, pain management experts. You may need to get physical therapists, occupational therapists, even psychiatrists at times to really target all the different aspects that create and modify pain. So that will be a critical part of the successful treatment.
And Dr. Phillips, I know you also really believe that it's important to do a thorough overall assessment of what's going on with someone, because while Parkinson's may be a key part of what's going on with someone's pain, it's important to make sure that it's not just Parkinsonian, that there may be an underlying infection or another injury of some form, that you've really got to do a careful overall assessment.
Absolutely, and I agree with both you and Dr. Ramirez that the treating neurologist is the place to start. When physicians undergo neurology training, before they specialize in Parkinson's disease, they undergo some general training, which includes familiarity with pain and the things that cause this, and the preliminary workup of this, as well as the preliminary treatment of it. So I think it's important, once we have ruled out that there's been any changes in dopamine medications, to look for other abnormal things in general health that could be going on. If you have, I see many patients that if they have a urinary tract infection or a cold, their motor symptoms get worse, and their pain symptoms also get worse. So that's something that people need to be educated on. I also think it's important to go to somebody that understands that pain happens in Parkinson's and that treatments may differ. It's often harder to treat in a lot of ways. So we need to move more quickly through our armamentarium than perhaps we do in other chronic pain conditions. And chronic pain has been very undertreated in this patient group, just because because physicians are nervous. I think everybody is scared right now of opioids, and I think when people think pain, they think opioids, and that's actually like one of the last things we do. But I think that there are multiple tools in our tool bag that we need to be thinking about when treating this.
Well, let's pursue that just a beat more, Dr. Phillips. And Tony, I'd love to get your perspective on this too, as someone living with Parkinson's disease, and that's the question of sort of fear of drug interactions. And it's an understandable fear. Parkinson's drugs are powerful. There's concern about how other drugs might interact with them. There's concern about how that might affect one cognitively in particular. And there's been so much attention paid, and appropriately so, to concern about opioid use in particular in this country. And you made the point a moment ago that we may tend to almost undertreat pain. So how do you sort through that, Dr. Phillips, so that we're not that we're proceeding with caution, but we're proceeding? Do you know what I mean? That we're not undertreating pain, so that we're not so fearful that we're hesitating unduly to treat pain when it needs to be treated.
Well, I think the first thing that you do is what you're doing today, and educating the people, both patients and physicians, that this is a real issue and that this needs to be treated. So I think that's the first step. Then I think you go through your systematic evaluation, and oftentimes we start with the least invasive things first. The whole do no harm. Something might help, but it certainly can't hurt. And oftentimes that's initiated with physical therapy. And they do things in physical therapy. People sometimes look at me like I'm crazy when I suggest physical therapy. And really, what you have to keep in mind is if you're in excruciating pain, they're going to start with things like heat, massage, and ultrasound, and then move on to some range of motion exercises. This isn't like going to the gym and doing a full court press. This is a gradual relaxation of the muscles and moving into other realms. This generally is a good starting point for most types of pain. And then we can move on to different medications. Again, if somebody comes in with excruciating sciatic or musculoskeletal pain, it's unlikely that one treatment will do the job. So in those patients, I'll commonly start therapy, but I'll also start some anti-inflammatories. I may start an antidepressant, which can be very good for nerve pain. And then we have interventionalists that do steroid injections and other things that can really be helpful. So I think it's important to start with the least invasive things. However, there are certain, that's kind of if it's a nagging chronic thing, but, somebody's getting by. If you're in excruciating pain, you need to be a little bit more aggressive. So, that's when clinical skills and familiarity comes in.
And Tony, from your perspective, walk us through kind of the way you've approached this, perhaps with gentler ideas, physical therapy, exercise, but also whether you've been open at times to treating pain more aggressively.
I believe at this point now that I've had the Parkinson's for 12 years, we treat the pain a little more aggressively. The opioids, the problem with that is that it creates constipation. So you're adding, if you have constipation issues, you're adding to the constipation. So we use that as a last resort. We treat it with medication, Botox treatments, and I go for injections every 3 months.
Is that for the dystonia?
That's for the dystonia, yes. And then for just a normal pain or whatever is normal for us, I'll use a painkiller. I also, non-pharmaceutical methods I use is I'll sit in the hot tub or the jacuzzi. I attend a boxing class, Tai Chi, and they very much help. And that's how I deal with the pain. And most importantly, socialization. That helps me with the pain.
And do you do that? sorry to interrupt, Tony. Do you do that with through working through your movement disorder specialist? I'm curious about who you work with or who guides you in the way in which you deal with your pain management.
Yes, my movement disorder specialist. She is the chairperson of my medical team. And and I will go to her first before I even take a vitamin. I will ask if that's okay with my medications that I take, because it's just so the medications could become harmful to you. So I just want to make certain that I'm taking the right dosage. And as far as exercising, I want to make sure I'm not going to get hurt. It's just to give you an example, and she's the one that told me I was way off base. I went for a 90-minute boxing class, and then I decided to ride my bicycle for an hour. Well, the pain I was in the next few days was incredible. And she told me that I exercised a bit too much. I should bring it down and ride my bicycle in 10-minute intervals and not ride for an hour after a 90-minute workout class. And so she'll guide me. I have a very good relationship with her.
Great, Tony. And I think getting that kind of ongoing guidance and having someone you can check in with and provide that sort of counsel is really useful. And I suspect that both Julie Phillips and Adolfo Ramirez were applauding when you said that you even talk with your movement disorder specialist about vitamins, because there's this tendency to think that you can take vitamins without talking to your doctor. And I bet they would both say, bravo for talking about that. Anyway, we'll let's bring in the other part of our equation today, which is fatigue, and because we want to talk some today about this intersection between pain and fatigue, and the way in which they intersect, and the way in which they can pose additional problems, and the way in which fatigue can also exacerbate pain, and pain can exacerbate fatigue. And let's start with some definitions of what fatigue actually is, because we all know that in Parkinson's, so often you can feel tired because we all have problems sleeping, but fatigue is actually something somewhat different. And Tony, let's start with your own sort of personal experience of fatigue, and then we'll get Dr. Ramirez to talk some about what it means from a more clinical standpoint. But when you have experienced fatigue, what does that mean? What does that feel like?
Well, it feels like as if I don't have the energy to do something, almost like apathy. It's just so close to apathy. I feel just exhausted. Like I don't know how else to explain it. I'm tired.
Even if you've had a good night's sleep.
Even if I could wake up feeling exhausted. I just
Okay.
had a 3-day stint of it, and I'm still exhausted. I'm just tired. And to get myself out of being tired is quite difficult, because now I'll walk my dog every few minutes. We'll go out, like I'd say every 20 minutes we go for a 10-minute walk, just to get myself out of feeling this way. I wish I could describe it better.
No, I think that's a good description. So pick it up from there, Dr. Ramirez, about what fatigue actually is, and why you experience it, as Tony just described, even if you might have had a good night's sleep.
Correct. I think that Tony's description of fatigue is very close to what we hear in our clinics. It's sometimes very hard to define fatigue in Parkinson's disease. And that has been a little bit of a difficulty over the past decade trying to find better treatments for fatigue, because one of the most important things to consider is that fatigue in Parkinson's disease is different from other problems that may that are common in Parkinson's and have a similar, cause a similar feeling to patients. So fatigue needs to be separated from feeling sleepy, depressed, or apathetic, like that lack of initiative, lack of assertiveness that sometimes patients experience. But I think that Tony is describing very, very closely what fatigue in Parkinson's is this sense of extreme exhaustion that it's not explained by medication side effects or by psychiatric disorders like being depressed or anxious, and that it's not improved with rest. Fatigue in Parkinson's disease can actually occur at rest. You don't need to be active to experience that sense of fatigue and exhaustion. And it can be commonly referred as an overwhelming sense of tiredness. There's lack of energy, and it's problematic when it starts interfering with normal function. It's very close to the definition of apathy. Apathy is a little bit different in the sense that apathy is a lack of desire. There's no drive to do things that are necessary for everyday life, and that can at times be difficult to separate from fatigue. But fatigue, it comes with this sense of tiredness and exhaustion, that it doesn't improve with rest. And the only thing that it has been shown consistently that may help with fatigue in Parkinson's is actually exercise. And that's a very important point because in general, but if you're tired and you exercise, you would expect that you're going to be even more tired. Well, fatigue in Parkinson's disease is different, and exercise improves fatigue in Parkinson's. And it's really important to separate from some of these other conditions, including sleep disorders. I think she mentioned that. So taking a nap or resting does not necessarily help with fatigue in Parkinson's.
And what about whether or not, we talked earlier about how getting your Parkinson's medications appropriately dosed helps pain, that if you're on correctly, if you're on the right level of dopaminergic drugs, that helps deal with pain. Does that apply to fatigue or not? Does being on help with fatigue, or does that not assist?
It
Are you
does.
asking me that
So,
question? Oh.
No, go ahead, Dr.
Sorry,
Ramirez.
Tony,
Actually.
Oh, okay. Yeah, the evolution of fatigue has not been well studied, and there's some limited information and studies looking at fatigue. There is, however, clear evidence that fatigue tends to be worse during the off periods, during off times. So just like similarly to pain in Parkinson's disease, the movement disorder neurologists, we try our best to maximize dopaminergic medications to try to avoid those off times, and that at times tends to help with fatigue and pain in most patients. So it's important to consider
and Tony,
that
go
as
ahead, please.
Part of the treatment.
Yeah, and I'm sorry, Tony, it would be great to get your perspective on that as well, your experience.
I did not notice a difference if I were off my medication or on my medication. If I felt fatigued that day, the entire day I feel like that until, as Dr. Ramirez said, exercising and getting myself out is fighting it, and it's a tough fight.
Right. I mean, it seems almost like a kind of oxymoron almost, that to be able to exercise when you feel fatigue sounds like a tremendous challenge. Dr. Phillips, what about the intersection between the experience of pain and fatigue? If you're feeling fatigued, does that increase your experience of pain and vice versa?
Absolutely. So I think that all of us can relate to a day when we're very tired, and you can think about anything external that you're exposed to. Your fuse might be a little shorter. I think that you don't see things the same way. And since pain is a perception of, it's a sensory perception. So your mindset can totally change your perception. I would like to echo, that exercising is great for both pain and fatigue. And, I think that there's not necessarily one way to exercise. This can be for some people, like Tony was mentioning, the Tai Chi or boxing. We at Albany offer boxing, spinning, and yoga as well. I think the other thing that Tony mentioned that I think is so helpful is, when you're fatigued or you're in pain, oftentimes exercise is the last thing you feel like. But if it's a social process and, your friends are expecting you and, I think this is another way that we all help one another get through this.
As we're talking about the ways that can help with fatigue, I've put up on the screen a slide that mentions some other things. And down at the bottom, we see the great vitamin question. I mentioned somewhat jokingly Tony's suggestion that you talk to your doc about even vitamins. And a number of people have actually written in about vitamins and what vitamins should we take. And I mention it in part because we have a tendency to think that, we can load up on vitamins. But there is, Dr. Ramirez, a reason why you ought to talk to your doc, because sometimes even with vitamins that we tend not to think of having any harmful effect, there can be interactions. What do we know about vitamin interactions, about the things that we should take or shouldn't take as they impact Parkinson's disease, and whether or not they can have any beneficial effect on pain and on fatigue?
Yeah, that's a very good point, Dave. I think it's really critical that patients talk to their doctors about what supplements may be indicated for their specific needs. I think that there's a perception that just because things are over the counter that they are safe, and some of these medications and supplements may actually have toxicity and can cause serious interactions with some of the medications that we use to treat Parkinson's disease. When it comes down to vitamins, even vitamin B, certain B6, for instance, can cause nerve damage if you take it at higher doses. Vitamin E, it's also another vitamin that if you take in excess, you can actually have toxicity related to higher levels of these vitamins. Magnesium, same thing. If you take high levels or high amounts of magnesium and the levels go really high in your blood, you can actually have worsening muscle weakness and difficulties with concentration and so forth. Unfortunately, we don't have, there are not evidence-based guidelines for the use of vitamin supplements in Parkinson's disease, and they have not been studied consistently in non-motor symptoms, including fatigue and pain. What we typically discuss with patients is that everybody may benefit from a different supplement, but you really want to know what works, the right doses to take, when to take it. We know that certain vitamins like vitamin B complex can be helpful with muscle cramps and spasms if you take them at night. So if you're experiencing pain because of that, a vitamin B complex could be quite useful. When it comes down to fatigue, the anecdotal experience is that vitamins can help at times, but not on everybody. So if as part of the workup of somebody that has prominent fatigue, and I should mention that up to more than 50% of patients with Parkinson's disease consider fatigue among the three most disabling symptoms. So it's a big problem for patients. As part of that workup, medical workup that includes ruling out medical causes of fatigue, medications that may cause fatigue, and so forth, most neurologists will definitely check vitamin levels, and if those levels are low, certainly supplementation is required. Now, if your levels are normal, then it really the discussion with your doctor and determining what may be good for you, it's going to be critical, as some people benefit from these medications, but not everybody. So you really have to tailor or custom the need of some of these supplements depending on your needs and the response to these medications.
We have a question, Dr. Ramirez, from Robert, who asks, what about caffeine, or as he puts it, other supplements, superfood, he writes supplements? Can those help with caffeine? We have also up on the screen wakefulness agents, stimulants. What's your view on those? Proceed with caution. What's your take on adding in those kinds of supplemental agents?
Let me talk about caffeine specifically. So caffeine has been studied in fatigue in Parkinson's disease, and it was not found to be effective in reducing fatigue, at least in a very small trial. It has also been considered as an agent to help with sleepiness, excessive daytime sleepiness. Part of the problems when you try to study some of these non-specific symptoms is that there's a big overlap with some similar feelings like sleepy, fatigue, or depression, or like Tony mentioned, lack of motivation that may account for some of these contradictory or inconclusive results. However, caffeine can be used and has been used as a stimulant in people that have early fatigue, and it may be helpful. The caveat is that sometimes if you take too much caffeine or if you have a clear worsening of the fatigue when the effect of caffeine is out of your system, you really want to minimize and limit the amount of caffeine that you take and resort to use other strategies, including exercise or socialization, to try to improve the fatigue. So caffeine in moderation, in low doses, if helpful, can be used, but it can also be detrimental if you take it at high doses or if your own body just reacts negatively when the effect of caffeine is out of your body.
All right, thank you. I want to put up one more item on the screen here, which is something we want to point to that we always like to do, which is to let people know the kinds of research that are going on. Dr. Ramirez just mentioned one study that has gone on with caffeine and fatigue. There are lots of other studies that are going on these various topics that have to do with both pain and fatigue. These are all things that you can find out about on our Fox Trial Finder that's available if you download our resource list. And if you're interested in participating in research, we really encourage you to take a look at that. There may be research trials that are going on with both pain and fatigue that you could participate in your area, and we always encourage people to participate in research. It's the best way that we can continue to make progress in Parkinson's disease research. So we encourage all of you to consider that going forward. Let's spend the rest of our time just answering as many questions as we can about this topic. And let's begin with a question that has come up about DBS, which is one of the things that we just saw a study about on that. And that's whether or not DBS can be effective in the treatment of pain in particular. It's an area that I know you've done some research in, Dr. Phillips. What can you tell us about the way in which DBS may be useful in this area?
Yes, so this is just starting to be realized that deep brain stimulation may provide some benefit. There's only about 10 papers on the topic, but in general, after DBS implantation in the short term, usually in the subthalamic nucleus, people report improvement in their pain symptoms. And, you know, this is independent of the improvement in their movement symptoms, which is quite interesting. So, you know, what the next step is, you know, we know this happens. We don't know how long it lasts, and we don't know what pains it's useful for. So Dr. Ramirez and I are actually working together to answer some of those questions currently.
Does that mean then, Dr. Phillips, that someone who has already had deep brain stimulation, that perhaps their DBS settings could be adjusted in a way that could further reduce pain, or do you know what I mean? So that their existing DBS could be further refined in some way?
Yeah, you know, and so we're actually looking at that right now. We have very preliminary data in a preclinical model, so meaning in animal studies, that if we alter some of those settings, we may be able to better treat some of the symptoms. You know, as we know, there's a big jump from animal data to human data, but we're just starting to explore that And then the other thing that I think, neurologists have noted for some time is that even if they had patients that didn't respond to one med prior to DBS, sometimes they have a different response after DBS, and that may be true with pain medications as well. So that's something we're looking into.
A couple of people have asked us to give us a better definition of off time, and my apologies. Sometimes there's a tendency to use terminology too casually when talking about something known as on time and off time. And Tony, why don't you just give us a good layperson's definition from a patient's point of view as to what we mean when we talk about on time and off time?
Okay. Well, the longer you have Parkinson's, you experience this on and off period. On is when your medicine is in full effect. Off is when your medication is starting to wear off. And that could be, for example, I take my medication every 2.5 hours. When I first started with Parkinson's, maybe the first year or so, I took my medication 3 times a day. So now at the period experiencing off, when I get to that 2.5 hour, I start an off period where my pain increases. And there are other symptoms that occur with the off period.
And one of the things that's being worked on a lot right now, and one of the hopes for breakthroughs in the coming few years, is to figure out new ways of delivering Parkinson's medications that even out those on and off times. So there's some new ways of delivering carbidopa-levodopa, for example, that will kind of even that out so that there won't be so many peaks and valleys, and on and off troughs will be experienced in a less volatile way. Here's an interesting question, Dr. Ramirez. I'll give this to you, Julie Phillips. Actually, this is a question. Someone says, what about exercise if you're in a wheelchair? Are there any options for someone in that circumstance?
Absolutely. And, I think it's, to fully explore what your options are, I think it's important to talk to a therapist or your neurologist as to what they think would work best for you. Having said that, there's many people that do chair yoga, and you can get the benefits of regular yoga through doing chair yoga, where there's a mind-body connection, and Tai Chi works similarly. So again, you may be doing modifications of these exercises, but I think it's important, if you're in a wheelchair, that isn't, you don't get a free pass from exercising. We still want you moving, because I fully believe in, use it or lose it.
Question about, and this often comes up really on really every topic having to do with Parkinson's disease, and whether or not this is something that can improve almost any symptom of Parkinson's, and that's about marijuana, Dr. Ramirez. And I think I know the answer, which is that we still don't know. That there's some research that's been done, and there's some, I think, legitimate interest in whether or not medicinal marijuana can be useful. But what's the latest on that?
Yeah, that's a very good question. Marijuana and cannabis compounds have been studied in Parkinson's disease, primarily looking at the effect of marijuana in dyskinesias and tremor. Some of the initial studies looking at that potential benefit have not been successful. They did not indicate a clear improvement either in dyskinesias and tremor. One of the main concerns with the use of marijuana is that it can also affect other parts of the brain, including memory, concentrations, and speed of processing information, which we know are affected by the disease itself. So the concern about potential side effects with the use of marijuana, it's a real one. I don't think we have a definitive answer. There is certainly interest in learning more about the potential benefits of marijuana for symptoms in Parkinson's disease in general, it hasn't been studied in fatigue, so we don't know how marijuana affects fatigue specifically. As a matter of fact, most of the medications that have been tested are stimulants and wakefulness agents, and marijuana it's more of a suppressant, inhibitory of the central nervous system. So we still don't know, but I would definitely be cautious about some of the reports out there. I think that we need to study the effects of these drugs systematically, come down with appropriate and safe conclusions to really guide and counsel our patients the best we can.
Tony, here's a question I'd like you to take a swing at. Question is, are there things that family members can do that can help someone, a loved one with Parkinson's who's experiencing pain or fatigue? I don't know whether that's aimed particularly at encouraging someone who's dealing with fatigue to exercise, but just be interested in your perspective in that, because this comes up often, whether it's you're dealing with questions of fatigue or apathy or depression, pain, because you often have an experience where a loved one wants to be helpful, wants to be encouraging. Sometimes that's welcome, sometimes it's not. What's your advice in terms of how to be helpful and how not to be helpful?
Well, I think especially with a care partner, it's important for them to get you up and going. Socialization is quite important. When I'm a little down and out or in severe pain, my husband will say, "Come on, let's go out. We need to go somewhere." Not that he's saying you're in pain, let's do something. He knows I'm not feeling well that day, and he'll get me up and going. Socialization is quite important. And it's just, even if you chat with one of your neighbors, it helps. It helps take your mind off of what's going on with your body, and you're talking about different things. Your life is not focused just on Parkinson's. If you're sitting alone in your home, that's all you can focus on is, okay, Parkinson's. But doing something different, even if you're creating a new recipe with your care partner, that has helped a lot, an awful lot. So my suggestion would be the strongest is socialization, besides exercising. That is just so important. Like I said before, I mentioned my dog. She even plays a part in being a care partner. It's when I am when I'm feeling not up and running, I make it a point to walk her frequently, just to get her out of the house, and myself. You run into neighbors, you say hi, and you just chit-chat, and that really does help.
Dr. Phillips, this is a question about alcohol. Is it something to be avoided? What's the relationship between alcohol intake and fatigue, perhaps in particular?
Yeah, so, I think that this kind of goes along the caffeine route in terms of moderation. I think that if you're going to have a glass of wine at dinner and you've talked about this with your neurologist and, you've reached an agreement that this is okay, I think this is fine. If you start using alcohol to sleep, I think this is a bad habit to get into, because then it gives you another problem to deal with. I think that it's more of a, used in that way, it's more of a self-medicator than it is, really solving the problem. And I kind of feel the same way, to be frank, about caffeine or wakefulness agents, where, if this is used in moderation, it's used occasionally, I have no problem. But if you have to depend on that at all, it's actually going to cause you more fatigue, and, then you're going to be sleepier and then probably in more pain.
Dr. Ramirez, here's an interesting question about how do you determine what kind of pain you're experiencing and whether or not that pain is pain due to aging, pain due to arthritis, pain due to Parkinson's disease. And it's always an interesting question as to whether or not what you're experiencing is attributable to Parkinson's or whether it's just attributable to the fact that you're of the age you are or whether it's something else that's going on in your body. Is that important to attribute it to the appropriate source, or is it really a distinction without much of a difference?
No, that's a great question. It is an important question, and in past years, neurologists, we didn't really think that pain or fatigue were part of the disease. Like, not that long ago, we considered Parkinson's disease exclusively a motor disorder, a disease that had tremors, slowness of movement, shuffling gait, and that's about it. Now we're finally understanding, and we now know that there are all these other symptoms that are part of the disease, and I think that's the initial step. When you are trying to find better treatments or help patients, you have to recognize this as part of the disease so you can move forward. And I think that determining what's the cause of pain, it's critical, because then you can guide the treatment to the specific source. And sometimes it's very difficult. Sometimes it's very challenging to say, well, is this pain coming from your back because you have some arthritis? Is it the Parkinson's disease doing it? I think that most of the time it's a combination of things. It's a multifactorial cause of pain. But we typically divide pain in Parkinson's disease at different levels, and we think that it could be a musculoskeletal pain. It could be dystonic if it happens just like Tony described beautifully when your medications are not working. We think about neuropathic pain, which is also common. And finally, sometimes central pain, that it's a pain that is related to perception and changes in the brain that alter the way that we experience pain itself. So making that separation is important, so you can guide patients to different treatment strategies, but they need to be complementary, because most of the time there's an overlap between the two of them. I don't think that you can attribute pain just to the process of aging. There's usually a source for the pain, and in most Parkinson's patients, there's always a contribution of Parkinson's causing pain. So in order to treat it properly, you need to consider all these options, do a comprehensive workup, and then determine what would be the best treatment individualized to the patient.
Just have a few minutes remaining, so let me just pose a last question or two as we begin to wrap up. Staying with you for a moment, Dr. Ramirez, what is it that you think we most need to still understand about pain and fatigue in Parkinson's disease? As both a clinician and a researcher, where would you like to see us focus our research that would be of the most help, I guess, to people living with these symptoms in Parkinson's disease?
Yes, so I think that one of the most critical aspects of treating pain and fatigue is understanding the mechanisms behind these symptoms. I think the research is going towards finding what are the mechanisms that cause, what happens in the brain before you develop some of these symptoms. I think it's critical to try to better understand the cause of fatigue and pain so we can treat it better. I think that the research is also going in the direction of finding objective markers of these symptoms, finding biomarkers or specific measures or objective measures that we can follow and monitor over time. That will be very helpful to try to develop better treatments, to assess their response to those treatments if we can identify those specific markers, biomarkers. In fatigue, there has been a suggestion that inflammatory markers are increased in patients with Parkinson's disease-related fatigue. So there's a lot of research going into doing imaging, brain imaging, to try to determine what areas of the brain may be more active or less active, accounting for pain and fatigue in Parkinson's disease. So I think that that's where we're going, because if we can understand those mechanisms better, we can also create or develop better treatments.
And Dr. Phillips, for you, your kind of best concluding advice, I guess, for patients who are contending with either pain or fatigue or both, about how they should, what they should consider as a way to contend with those symptoms.
I think the best thing is to have an open dialogue with your neurologist, with yourself, and with your family, so that you can look at all the issues that might be causing your pain and fatigue. Sometimes we don't realize, how many stressors in life we have in terms of not just Parkinson's or general health, but also in our relationships and things that are going on. And so I think to take a minute to reflect on what's going on in your life is very important. And then I think Tony brought up gave some very good advice in terms of socializing and even getting out of the house and making her dog her exercise partner. If you generally put something else above you for that minute in time when you're dealing with these things like pain and fatigue, which can get so overwhelming if you're left to your own devices in your head, that can be a really effective treatment as well.
Nicely put. Thank you. Tony Palumbo, last quick thought from you as well, please.
I agree with both doctors. I mean, they're excellent with their advice. Excellent. I believe exercise is one of the keys, not only for pain and fatigue, but for many other symptoms in Parkinson's. And exercise. That would be my recommendation to everyone. And always speak to your neurologist. Make it a point
even about
that whatever you're doing, your exercise program, taking vitamins, changing your medication, adding on medication, you have a question, you need to have an open dialogue with your neurologist, your movement specialist. That's quite important.
Tony Palumbo, Julie Phillips, Adolfo Ramirez. Thanks all so very much for participating in this really helpful, I think, important conversation about pain and fatigue and Parkinson's disease. And thanks to everyone for participating in our continuing Third Thursday webinar series. Really appreciate everyone participating. We'll be sending a link to the webinar on demand series, so you can listen again and share with others as you'd like. There'll also be a survey link in that email as well, so that you can also share with us your thoughts on today's presentation. And we'd also like you to mark your calendars for our next Third Thursday webinar, which will be on August the 18th. When we'll be taking up the topic of atypical Parkinsonisms. That will be a week from now on Thursday, August the 18th. Until then, I'm Dave Iverson. Have a great month, everyone.